All right, it looks like we are at the top of the noon hour. So thank you everybody for joining us today. This is session 3 of our Pathways to Language Echo, and we're so excited for you all to be here today. So this Echo series is sponsored by the North Dakota Early Hearing Detection and Intervention Program. The purpose of this series is to enhance knowledge of the EHDI system, and our goal is to build state and territorial level data and measurement capacity to improve language acquisition outcomes for children who are deaf or who are hard of hearing. Before we begin, we want to describe what sets Echo sessions apart from other trainings. So in essence, Echo allows us to move information and not people. It allows you to actively learn about a topic and become a resource for your community. So each session, there's going to be a formal didactic portion on a specific topic, and then we're going to follow it up with a case presentation. We do encourage you to ask questions in the chat or by unmuting during the Q&A portion of each of these presentations. And we want to highlight that your participation is really the success to our Echo sessions. We really want to have that interactive community where presenters, stakeholders, and community members all communicate and support each other during these sessions. So we do encourage you to turn on your camera if you are comfortable doing so. And please feel free to ask questions after the didactic portion by either putting your questions in the chat or unmuting during that time. Also, please feel free to give feedback during our case presentations. And if you are working with a kiddo that maybe you would like to feature as a case to get some direct advice from our subject matter experts, please feel free to reach out to me and we will gladly work with you to incorporate that into a future session. Just a heads up, we really care about confidentiality. So if you are presenting a case, please do not share any identifying personal information of that person. And you can earn professional development credits for participating in the live session today. We are offering social work and nursing CEUs. We ask that you complete the evaluation form that will be posted in the chat. You can also reach the evaluation form through iEcho. If you go to the scheduled and then go to that day's session, you'll see a submit feedback form right over today's session, where you would typically join. So now we're going to introduce our speaker for today, Dr. Jocelyn Martin. Dr. Martin is a pediatric audiologist who specializes in diagnostic audiology and early hearing detection and intervention at the Mayo Clinic. She ran their newborn screening program for years, and she was instrumental in getting the CMV screening protocols in Minnesota. So please help me in welcoming Dr. Martin.
Hello, thank you very much. I am going to do my best to share my screen because I have a bunch of slides to share. And see if I can get them into presenter mode. And see, how does that look? Can you see my slides now?
That looks great.
All right, terrific. Oh, I'm gonna move another thing. There we go. All right. So thanks for having me. Thanks for inviting me, and welcome to this presentation about sort of audiology's perspective on early identification of hearing differences. As you heard, I'm Dr. Jocelyn Martin. And advance my slides that way. There we go. I'll tell you a little bit more about myself first. I'm a licensed and board certified pediatric audiologist here in Rochester, Minnesota. And I serve as Mayo Clinic's EHDI coordinator and have managed this newborn hearing screening program since we started it in 1999. In many newborn hearing screening programs, nurses tend to be the people doing the screenings, and then audiologists only work with families after there's a refer result on that inpatient screening. I'm in a really pretty unique position here at Mayo Clinic to be an audiologist who coordinates the inpatient screening program. So I actually screen one day each week myself, and then I have some administrative time to try to make sure that all aspects of our EHDI system run pretty smoothly. In addition to that responsibility, I also spend about half of my time here at the clinic working with patients of all ages and their families in our hearing aid program. I fit hearing devices and help support patients and their families for those that choose the hearing device pathway. There we are. So achieving early and accurate screening, identification, and intervention, we know, takes everyone working together. It's why I'm so excited to be speaking to you as part of this series. Today, I'll be focusing on the role of newborn hearing screening in early detection of hearing differences, but we'll actually touch on a few of the other topics that are listed as focus areas in this Pathway to Language series. I know that we have so many perspectives represented here today. I looked a little bit in the chat. I'm going to try to focus on what I want to say more, but attending a previous session, I know that we have so many perspectives, so many places geographically as well represented here. And so I'm pretty excited about that. I know this presentation then won't be all things to everyone, but I've tried to craft it so that everyone attending will find something that's helpful to them in their work with infants and children and their families. In my practice, I think of EHDI as the umbrella term that includes a number of the activities that are shown on this slide. The one we'll talk the most about today, of course, is the inpatient newborn hearing screening. In addition to newborn hearing screening, we'll also spend some time talking about short and long-term follow-up, as well as talking about interested parties and what I like to call interprofessional relations. When I'm talking about short-term follow-up, at least in my world, I think everyone has probably some different ideas about this too, but these to me are the outpatient rescreens that happen for us at about 1 to 2 weeks after hospital dismissal for those that are leaving the hospital with a refer result. When I'm talking about long-term follow-up, I'm talking about ensuring that children who are identified with a hearing difference receive timely and appropriate diagnostic evaluations in audiology and get connected to all of the services that they need. Then we work with a number of interested parties such as nursing, primary care providers, specialty physicians in ENT, genetics, infectious disease, ophthalmology, and the list kind of goes on a little bit more too sometimes. We also work with early childhood educators, teachers, and probably most importantly, parents. While I coordinate Mayo Clinic's EHDI efforts, you all heard in a previous presentation about the larger EHDI system. States have their own EHDI coordinator or coordinators, and then the work of EHDI, is funded by multiple agencies in the US. So we're one little hospital that's part of a state that's part of this whole bigger system. Talking a little bit about the data shows that approximately 1 to 2 per 1,000 babies in the US will be born with a hearing difference. This difference may be profound, bilateral, and sensory neural, or it can really vary by degree. The hearing difference may be in just one or both ears, and it could be sensory neural, where that hearing difference is in the cochlea or in the 8th cranial nerve. It could be conductive, where that hearing difference comes from the ear canal, the eardrum, or the middle ear space, or it could be some combination of conductive and sensory neural, and then we call it a mixed hearing difference. Studies vary on the prevalence of hearing difference that occurs later, but everyone agrees that more children will be expected to have late onset of a hearing difference or a progression of their existing hearing difference. So newborn hearing screening programs aim to identify most, if not all, of the hearing difference in newborns. Quick aside, if the photo in this slide looks just a little bit older, it's because it is. The baby in this photo is actually a recent audiology student extern that I worked with. Her parents, while she was here in her externship, sent her a photo of her own newborn hearing screening, and she gave me permission to share it with you all. She is now a full-fledged audiologist who works with us here at Mayo Clinic. I thought that would be kind of fun to share, and it also makes me feel kind of old. Let's see, let's talk a little bit about what I call inpatient newborn hearing screening. My perspective, of course, is screening in the hospital, but we also know that there are out-of-hospital births, say attended, for example, by midwives. You'll find that I tend to use the term inpatient screening to describe the birth screening, whether it's done in an actual hospital or birth center or associated with a home birth. So pardon me if I go hospital on you occasionally. I typically talk about babies that need to be screened using the term well child to describe the population of children who room in with their parents after they're born, and using the term NICU to mean any child who spends time in the neonatal intensive care unit. Another quick funny side story, I hope you'll find it funny. When we were developing our newborn hearing screening program in the late 90s, I was talking to my then fiance about well child versus NICU. And he stopped me and said, how many well children are there? And we had miscommunications for several minutes. It took longer than I'd care to admit to realize that he thought I was talking about screening children who got stuck in a well. I'm old enough to remember baby Jessica, who was in the news when she was stuck in the bottom of a well in 1987. Maybe many of you are not, but I am. And apparently that was who he was picturing that we were going to be screening. So, okay, back to it. In the well child population, babies typically get screened when they're about a day old. We know that can vary by program and by who's conducting the screening. The length of hospital stay for these children has gotten shorter, like significantly shorter, and especially so during the height of the COVID-19 pandemic. So we are always trying to balance our ability to screen them when they're old enough for the vernix that they're born covered in, that sort of white material babies are born covered in. We want to make sure that has a chance to dry whenever we can, because it often gets in ear canals and makes it harder for us to conduct the hearing screening. So we want to make sure they're, as old as we can get them, but also not wait so long that we delay their planned dismissal from the hospital or miss actually getting to screen them. In the NICU populations, screening is typically offered when a baby is getting closer to going home. Again, this can vary by hospital, but most that I've talked to will have some sort of set of criteria that they use to determine when babies are ready to be screened. Let's see here. In our hospital, hang on a second. There it is. I messed up a little slide transition for you there. Our hospital uses what we call the ROAD criteria. ROAD stands as an acronym that stands for respiratory, oral, age, and dismissal. So in our hospital, we are looking for most of our babies to be on low flow oxygen or on room air before they sort of are in that space where we typically screen them. We are looking for them to be working on oral feedings, and we're typically looking for a gestational age that's at least 32 weeks and are usually getting closer to going home sort of in the 1 to 2 weeks. It's our neonatology teams that use this criteria to kind of decide when to ask us to come and do screening. And this cute little clip art sign that says hearing screening in process is a laminated sign that we actually keep on our hearing screening cart. We tape this to the door of the room when we go in to do newborn hearing screenings. It helps the nurses and the physicians know that we're in the room so that they don't come in with really loud voices, for instance. It also lets family and friends who are visiting to know to either wait until we're finished or to come in relatively quietly. And it's been kind of a nice little piece of our program. There are two main types of screenings that are typically used in newborn hearing screening programs. They're called otoacoustic emissions and automated auditory brainstem response. Either or both technologies per the Joint Commission on Infant Hearing may be used in the postpartum setting, again, what we would call the well baby or well child setting, and in the NICU setting, AABR is the recommended screening. Otoacoustic emissions are very quiet sounds that are produced by the active processes of the hair cells of the inner ear. In the OAE screening, the equipment plays a stimulus. It can be tones or it can be a clicking sound. Then the equipment can measure a response right after that stimulus. It does a whole bunch of these and averages them all together. And then the equipment determines whether there's enough of that emission present in order to be considered a passing result or not. In the case of an auditory brainstem response, this is a test where it's a waveform response that we're looking at that can be measured using sticker electrodes after a stimulus is presented. In the automated version of this, or the AABR screening, the equipment plays a clicking sound. And I said clicking twice now, but a clicking sound sort of sounds like a brrr kind of a sound. So that's what the baby is getting to have in their ear. Then the stickers on the baby can measure the response in the 10 or 20 milliseconds after each click. Those responses then are averaged, and the equipment uses an algorithm to determine whether there's enough of a response to be considered a passing result or not. In both of the screenings, I like to tell families that the baby doesn't have to jump, startle, raise their hand in response to the sound. In fact, it's actually easier to run any of these screenings when babies are asleep. Again, either or both technologies can be appropriately used in the well child setting, but in the NICU setting, AABR is the only recommended screening. Neither screening technology is perfect on its own, and there are actually pros and cons to each type of screening. For instance, the otoacoustic emission screening is frequency specific, faster, and less expensive, and the AABR goes a little higher up the auditory pathway. So yeah, there really are pros and cons with these. Moving into, kind of the ways that babies will kind of pass through our newborn screening. There are 4 main pathways that babies will take once they have their hearing screened. When there's a screen pass result, they are basically finished with the newborn hearing screening initial process and will next have their hearing checked or screened by their primary care provider and possibly when they're going through early childhood screening. In the second sort of pathway, there might be a screen pass result, and then there are risk factors present for that child for later onset or progressive hearing difference. In that case, it is recommended that those children have an audiology evaluation by 9 months of age. In the 2 categories where there's a screen refer result, in the first one, there's typically, at least for our practice and a lot of places that when I've talked to others, this is the way that it works in some of those places. Others, they might go a slightly different path, but in ours, there's often an outpatient rescreen. If there's a passing result on that outpatient rescreen, then they again would be finished with that newborn hearing screening process and would next have their hearing screened by their primary care provider and through early childhood screening. When there's a screen refer and then a refer result on the outpatient rescreen, an audiology evaluation can identify when there is a permanent hearing difference. Family-centered care is really important to me, and it's been important to the families with whom we work. We really try to keep an emphasis on family-centered care in a number of ways. Things that we do some of the things that we do are listed here. We offer to screen in the room with parents present. And I would say most of the time we find that that is what families want. They want to be there for most of the things that their baby is going through. If I want to be really technical about it, family-centered care might actually mean means whatever that is that the family wants. And so once in a while, there are families who will say, I don't want to watch, take baby somewhere else to do this. And that would also be family-centered care. But I would say for the majority of our families, they prefer to have a screen in the room with them present. If family is present, it's really important to explain what's happening. We want to make sure that we help to sort of demystify the process and reduce fear for the parents and other family members who may be present for that. It's also really important to give results as soon as the screening is completed. I actually often say the equipment doesn't tell me much while it's running, but as soon as it finishes, it will tell me, and I can tell you what the result is. It's been my experience that this simple statement often helps families worry just a little bit less during the screening. It's also really important to provide written documentation of the results of the screening to families. Most screening materials that I've seen also include early development milestones for hearing and for speech and language. It's then also really important to make sure to share these results with the state EHDI program, especially for children and families who may change providers or hospitals. It can really be the EHDI program that can help families get connected to services and to intervention. Other items that I think make screening and follow-up go smoothly include communicating with inpatient providers. For instance, the nurse working with a baby and their family, that person usually knows exactly what is going on for that family, and they can be so helpful for us in making sure that we get the timing of the screening correct. Many providers want to visit families during their hospital stay, including primary care, lactation consultants, midwives, nursing students, and the list goes on. And so it's really important to make sure that we are all able to get in to see these families, but also to do our best to not overwhelm them as well. We know that offering an appointment before a family leaves the hospital increases the likelihood that they will make that appointment and keep that outpatient appointment. So whenever it's possible to make an outpatient appointment before they leave, we know that that makes a pretty big difference. Another thing that's really important is documenting in the medical record in a way that will be read by the primary care provider. Over the years, that's changed a little bit for us, but it is so important. We also know that primary care provider encouragement is kind of the #1 most effective way to get families to return for follow-up. So we want to find a way to make sure that the primary provider who the patient gets established with will actually be able to find that information. I'm spoiled rotten the way that I'm saying this. I know that in my system, the primary care provider can see all of the inpatient notes because they're part of the same system. And I know that's not the case everywhere. Another thing that I just threw on there is to consider CMV screening. Now, that's not to be taken lightly. It's kind of a big deal and everything, of course. But we have seen in targeted and universal screening in our hospital and in general in Minnesota that families are more likely to follow up for hearing things when CMV is identified. So let me take a quick little detour here to share just a few comments about screening for congenital cytomegalovirus, or CCMV. CMV is a common virus that is present in bodily fluids. It causes a mild illness in children and adults. When a pregnant person is infected with CMV, though, we know that they can pass it on to the baby. Approximately 1 per 200 babies are born with CCMV. And while there's a widely variable presentation of this, some of the symptoms can include growth problems, seizures, hearing difference, vision loss, developmental delays, and disorders of the brain, liver, and spleen. Testing for CMV is done by collecting a sample of urine or blood or saliva, and it has to occur by 21 days of life in order for us to differentiate whether it was a congenital infection or acquired. If it was acquired after birth, we don't really have big concerns that it will have significant negative impacts on the child. With recent research efforts focused on this virus, we are learning that CCMV is the leading non-genetic cause of hearing loss in newborns and young children. In 2018, we began conducting targeted screening for CCMV at our hospital. There are other hospitals that have started this as well. Targeted screening in this case means that anyone who is going to leave the hospital with a refer result on their hearing screening would get a CMV test before that hospital dismissal. And again, that's how we do it. Urine is the preferred specimen collection for targeted screening, as the viral load is highest in urine, making it a little easier to detect. Saliva is used as a backup in the event that it isn't possible to get a urine collection before the baby leaves the hospital. Seems silly to say, but if we finish our hearing screening and get a refer result and they're leaving in the next hour and baby doesn't pee in their diaper before they leave the hospital, then they might have to do a saliva swab. In 2023, Minnesota became the first state to screen all newborns for CCMV. In our statewide newborn hearing screening, in our statewide screening program, dried blood spots are used to conduct the screening. If there is a positive result on the dried blood spot, then urine confirmation is ordered. Once CCMV is identified in a newborn, then it's recommended that they receive a physical examination looking for signs and symptoms of CCMV. Some of those might be microcephaly, an enlarged liver or spleen, jaundice, certain specific types of skin rashes, and certain neurologic findings. It's also recommended that they get blood work. Typically, I'm told, not my area of expertise, but I'm told that that includes complete blood count and liver function tests. It is also recommended that they receive head imaging. Typically, that's an ultrasound, and occasionally might be an MRI, again, depending on findings. And then it's also recommended that they receive an eye exam and a hearing evaluation. If any overt signs or symptoms of CMV are present on any of these, then a consultation with a pediatric infectious disease provider is also recommended. It's the pediatric infectious disease provider who can discuss potential treatment with antiviral medications with the family in case that's potentially indicated. When it comes to audiology follow-up for those with CCMV, our Minnesota Department of Health convened a group of audiologists from around the state to develop an audiology monitoring plan. Since there's not enough yet data telling us when hearing tends to change for children with CCMV, we opted to include hearing evaluations at very regular intervals in the first 2 years, and then move to less frequent assessments as the children get older. Let me hop on a quick little soapbox here to say that when it comes to pediatric audiology evaluations, if you are an audiologist and do not consider yourself an experienced pediatric audiologist, I really encourage you to find one. Network with them, work together to provide better and more widespread pediatric audiology services in your area. If you are a pediatric audiologist and you know another audiologist who you think is good with kids, please mentor them, encourage them. The world needs more pediatric audiologists. Okay, back off that soapbox for a second. When a baby leaves the hospital with a refer result, again, we would sometimes first schedule them for an outpatient rescreening. In some systems, they may go right to a full diagnostic audiologic evaluation. That evaluation typically includes a number of things, and they are listed here. One of the first things that is sort of on that list is a tympanogram. In the case of a tympanogram, we put a headphone in a baby's ear canal, and that headphone can change the pressure. There's a little more to it, but this gives us basically a measurement of middle ear function. For example, it gives us an idea of how well that eardrum is able to move back and forth. The test battery might also include acoustic reflexes, but not every time. In this test, it's conducted using the same equipment that we use to do the tympanogram. We play sort of a louder sound and can measure using eardrum movement whether that reflex is present. If you're someone who isn't very familiar with the concept of reflexes, think about like when you go into a doctor's office and they do the little knee jerk reflex where they kind of hit the top of the knee, and then then they're kind of looking for the leg to kick. In that case, we aren't testing the knee or the leg, but rather the pathway of nerves that has to go up and back down in order to get that reflex. In an acoustic reflex, we're able to actually test the integrity of portions of the 8th and the 7th cranial nerves when we're doing that acoustic reflex. Then when it comes to otoacoustic emissions, OAE, as we talked about before, are a measurement of cochlear function. The audiologist uses this in more than just a screening method. We can actually use the OAE in a number of different capacities to look at how parts of the inner ear are functioning. And then in a threshold ABR, this is set up a bit like the screening, right? Where there are sticker electrodes typically on forehead, back of the neck, a few other places potentially. This time in the diagnostic version, the audiologist is actually looking at the waveform response. So it's not that the equipment says it's there or it's not. The audiologist is looking at the waveform response. Then the audiologist can conduct this evaluation at multiple different frequencies or pitches and at different intensities or loudness levels. This is also able to be done by air conduction with a headphone in the ear canal or over it, but typically in it. And it can also be done by bone conduction, where there's a headphone that's placed behind the ear. When we are doing this by air and bone conduction, then we're looking to sort of narrow down what the type of hearing difference is. We're looking at whether that might be sensory neural or conductive or mixed. The audiologist again looks at that waveform data to try to figure out how loud of a sound it typically takes for the child's auditory pathway to process it. When it is technically a test of neurologic function, we can actually use the ABR to determine how much of a hearing difference there is on each given ear. Sometimes it can take 2 appointments to get all the information we need, but it is our goal to get enough information to determine type and degree of hearing difference in each ear in order to be able to initiate interventions such as hearing aids or cochlear implants when those are chosen by the family. I think it's really important to explain that family-centered principles apply here as well. It's really important as one is going through this evaluation to tell the family what you're doing. Give results as you go. For example, with tympanograms, I might say something like, this test looks at how the eardrum moves, and this result right here suggests that the eardrum is moving well today. That means that we're less worried about ear infections or fluid making it harder for the baby to hear. Once you've described the parts, each part of the evaluation, the family may come to their own conclusions and state what you need them to know, that there is potentially an educationally significant hearing difference. If they don't come to that on their own, you may actually have to explain to them in specific terms, but it's really important to use clear language and all the while trying to do your best to be kind and gentle about it. When I went to school to be an audiologist, and we've already established that that was a few years ago, I learned about the list of things that families needed to know. And that as their professional expert, it was my job to make sure that I told them exactly what was on that list. I learned pretty quickly from Chris English, and her book with John Greer Clark is referenced on this slide, that it was actually my job to meet each family where they were. I learned instead of trying to share my list, to ask, okay, here's what we know. What do you need to know next during an evaluation? And what I actually found was that sometimes what families needed to know in that next moment didn't really align with my checklist. And it turns out, as I've learned over several years of doing this, families will ask for the information in the order and the speed with which they're really ready to digest it. So it's really important to try to meet each family where they're at and kind of follow their lead. It's their journey, and we are just on the ride with them to support them. As I mentioned earlier, achieving early and accurate screening, identification, and intervention takes everyone really working together. So when a hearing difference is identified, we get families connected to other medical providers for additional evaluations. So this typically includes at least an ear, nose, and throat physician, ophthalmology, and genetics. And it may, as I mentioned before, include others as needed for each individual child and family and whatever happens to be going on for them at that moment. Oh, one more thing about that. It is oftentimes the primary care provider, of course, that is really doing this. I make it sound like audiology does all of these things. We do not always. It is typically the primary care provider that is ordering all of the right things and everything, but it is our job to consult with them and to make sure that every child gets the resources that they need. It's also really important to connect families to non-medical resources, of course, as well. I know that newborn hearing screening is not currently mandated in North Dakota, but the state EHDI program website, and again, I know we're attendees from all over the place here, but I spent a little time kind of looking that way. And I know that the state EHDI program website is full of great resources to help professionals find them and get their patients connected to them. First and foremost, it's really so important to report audiology results to the state EHDI program and to the Part C early intervention system. We also know that deaf mentor programs and hands and voices guides are also such great resources for families. As I asked around, I heard some pretty great comments about how a lot of these programs operate in North Dakota. It's part of our responsibility as an audiologist to know what resources are available. So when I run our audiology student externs pediatric rotation, so we have students who are in their 4th year of their audiology doctoral program, I give them an assignment to research and compile a digestible list of resources. So they can go anywhere to find the information, and they can put it all together in a format of their choosing. It can be PowerPoint, it can be a Word document, it can be something different if they want. They can put it together in a song, I don't know. I just want to make sure that they go out and research what all is out there. And then after they've researched it and they've put it together, I ask them to share this with our larger pediatric group of providers. I always remind them that this is their real life responsibility as well. It's not just a lame student assignment. If I move to, I'm just going to pick on North Dakota again tomorrow, for instance, it would be my responsibility to look up and become familiar with the resources available in the area that are helpful for caring for the children with hearing difference in my practice. And one more plug for working together. Educational and clinical audiologists get to know each other, and maybe you already do. The connection I have with our local educational audiologists is really special. I can email or call any one of them and I can get a really quick response. We all know that we each have like the best interest of any given child and family in mind. Sometimes I have quick interactions with the educational audiologist, and once in a while I've had like 40-minute long conversations where the discussion around one shared student leads us to thinking about another and another until we have solved everyone's issues and concerns. Okay, that's a joke, not really. But we really do help a lot of students get what they need when they need it by intentionally fostering those open lines of communication. I have worked with families for whom the identification of a hearing difference was a sad event. And I have also worked with families for whom the identification of a hearing difference was a reason for celebration. In either scenario, newborn hearing screening helps us to identify those children with hearing difference at a very early age, ensuring that children and families get connected to the agencies, the services, and the interventions that they need in order to learn language and reach their potential, both in school and in life. As an audiologist, I've had the opportunity to follow many of these children now into adulthood. I didn't realize the theme of this was I'm old. But it has been such a rewarding experience to be involved in the early identification and then to support these children and their families over time. Children can grow to lead successful lives in part because of the difference newborn hearing screening has made. So thank you very much. I was invited to share this presentation, but I would like to make sure that you know that I'm part of a larger pediatric audiology team in Rochester that is so passionate about providing the best care to every child and family every day. And we are just one hospital system that is part of the larger EHDI system in our state and throughout the country. So thank you to each and every one of you attending here today for what you do to support families in their journey through early hearing detection and intervention. I did list my email here, so if you have additional questions, please feel free to reach out to me, or as you already heard, feel free to reach out through the ECHO program. So I am really looking forward to hearing next the family story. And I don't know if there are time for questions. Or is time for questions?
Yeah, I think we have a couple minutes for questions, and we do have a couple in the chat. And thank you so much for that wonderful presentation. One person asked, are the risk factors included for the 9-month reevaluation after the screening primarily based on history, genetics, neuro, or is this based on the performance of the screening, like borderline scoring, response, or both?
Gotcha. The risk factors are specific to the baby, not the screening. So I did not include this here, but the Joint Commission on Infant Hearing, their most recent report has a really wonderful graph that actually lists what those risk factors are for later onset. Most of them I'm not going to say this well, but the biggest risk factor that we see is a NICU stay of greater than 5 days or more. So typically most of the risk factors will sort of fall underneath that, but there are multiple different risk factors, from family history of childhood hearing loss to a variety of different infections, to craniofacial differences, some different things like that. So looking at the Joint Commission on Infant Hearing is a great way to locate a bigger list of those. Next presentation, I will include that list. Thanks for the question.
Yes, and one more question. What's the sensitivity rate for Minnesota's universal CMV screening process?
Great question, and I don't have that at my fingertips right now. So I would have to probably get back to you on that one. How's that?
Yeah, that's fine. We can try to get some resources or some articles and put that in our additional resources that we typically put together for the end of the session.
That
So
would
thank you
probably
for that
answer
great
that
question.
question way better and some more. Yeah.
Yeah, that sounds good. Um, oh, and Kathleen said she's going to email you.
Perfect.
All right, well, I will introduce our case presenter. Before we do that, thank you, Renee, for providing interpretation for us. Do you need a break, and would you like us to swap you out with Donna? Yes? Perfect. I will go ahead and add a spotlight, and um, I would like to introduce Deneen Feist, our our case presenter for today. So thank you so much for being here, Deneen.
Thank you. I can't see the screens though. I mean, the, I can't see my present. Okay. So thanks for having me today. I'm hoping that my family story will resonate with some of you. And thank you, Dr. Martin, for really emphasizing the family-centered care piece. I've been been an advocate for many years. And it is in part because of my son who was diagnosed. So I am the director for Family Voices of North Dakota. Our story is full of celebration, but it's also full of things that probably could have been done a little bit better. Next slide, Krista. So Zach is the little guy on the right-hand side of that picture. He had kind of his cord was wrapped around his neck when he was born. When after he was born, he had it felt like we had nonstop ear infections from the time that we brought him home. He had a very slow language development. We had many clinic visits, and I kept saying to our general practitioner that there was something wrong with Zach, and he kind of poo-pooed me a little bit, and he said, "You're a nurse, you know too much. He's slow at speech. He'll catch up." And so essentially, we had to um, get another opinion, a second opinion, and we went further for that. So getting that diagnosis was not easy because he wouldn't, at that time we were on a HMO and he would not provide the referral. So we had to just go out of network to do that. And Zach was essentially diagnosed with a severe to profound loss. It was very overwhelming. That was probably the most overwhelming day I think that I've experienced, and it is really quite, I don't want to say it's funny, but it's that day that a family receives that diagnosis, you will never forget it. Um, and you also remember almost everything that happened in that process. When they actually did give Zach a diagnosis, my two little ones there are 10 months apart in age. And so I had Zach on one knee and my daughter on the other knee. And the first thing that the ENT and the audiologist that we had gone to were in the room with us when they were giving us the diagnosis. And I don't remember which one said the words that he said, but he said, "Your daughter will far exceed anything that Zach will ever be able to do." And it was at that point that I would have to say that I remember distinctly watching their mouths moving, but I wasn't comprehending anything that was being said to me. So anyway, it was quite overwhelming. Next slide, Krista. So while we were at that appointment, we were 2 hours away from where we normally would go to a physician. So there was a financial impact. They wanted us to come to Fargo 3 times a week for speech. And at this point, Zach he didn't get diagnosed until he was almost 2.9 years old, even though we had tried to get a diagnosis much earlier. They had us buying 2 sets of hearing aids. They had us buying an auditory trainer. I mean, all of this was kind of impacting that appointment too. Like, where in the dickens are we going to get this money from? And who is going to help us? So I was a young mom then in those days, and advocacy was not on my radar, to say the very least. So when we got back, there was a local family who also had a child that was deaf and hard of hearing. And had I not known about her, I don't know how we would have actually survived. It was her mentorship really that got us connected. I asked other folks to, is there somebody else that I can talk to, a parent? And in those days, you couldn't connect with another parent because there was no groups. There was no hands and voices at that time. There was no family voices at that time. So it made it really difficult. I did get a new audiologist, and I am ever so grateful for, because we ended up getting a second opinion, and I'm so grateful to her because she was trained at Minot State, so kudos Minot State. And she also had a son that had a sensory neural loss as well. So of course I had a ton of questions with her. And she became like such a huge support to us. So I had questions like, well, she brought Scott into one of our follow-up appointments so that I could be introduced to Scott. And of course, he was older. And so I had questions like, do you have a girlfriend? I mean, all these things kind of run through your mind when you receive a new diagnosis. So I didn't know if Zach was going to end up being our priest or, all these crazy things kind of run through your head. And so from there, she helped get us connected with our special ed unit and that whole process. And she also wanted to make sure that she was providing, or the special ed unit was providing the services that Zach needed in the school setting. So we were sent up again to Minot State to assist in that IEP development. And I don't know if they're on the call, but they are now part of the North Dakota Deaf Outreach Program. And they were students at that time. So every time Zach completed an assessment that they were doing, he got a toy. And so we ended up with a huge basket full of toys. So of course, every day Zach wanted to go back to Minot so that he could continue to get some of these toys that he would do for the assessment. And he was ever so disappointed at further assessments when he would do an assessment and he didn't get a toy. So it ended up being kind of a thing. Our superintendent and principal were not always real happy that I should just say it this way. They wanted me to send Zach up to the School of the Deaf, and that just wasn't an option for us. And they got a little bit obstinate with me because I did not want to do that. It just wasn't the right choice for our family. So again, Dr. Martin, thanks for bringing up family-centered care, because that is so important and vital from the beginning. From all of this, our special ed director At the time, the Interagency Coordinating Council, who deals with issues birth to 3, they had started a family involvement subcommittee, and she asked if I would be okay with her submitting my name for that. And of course, I said, sure, why not? But I mean, I didn't absolutely understand what that meant. So it was kind of an interesting role that came about, kind of fluky, I would say. And I was really grateful for the teachers of the deaf and hard of hearing that were also at our school because of the other student that was in our school. And that that picture right there on the bottom, I just have to say that Zach and my older son there had ADHD, and he also had significant allergies. So when he had to get a nebulizer quite often, which would send him flying. Zach couldn't hear. I mean, it almost felt like a 3-ring circus at our house at times, but so I just had to throw that picture in there. Next slide, Krista. So Zach started what was at that time called a reverse integrated preschool. So the preschool was designed for children with disabilities and special health care needs, while students from the general education division would get integrated in to for peer support and things like that. Our audiologist went to the IEP meetings with me to help staff understand what his needs were, like putting carpet underneath the desk so that it would absorb some of the sound and it didn't echo, things like that. We also started to notice things that motivated Zach and things that isolated Zach, and he fluctuated quite a bit between motivation and isolation. So it was sometimes real frustrating. His motivation was at a very young age was sports, very young age. So he was very active in t-ball and baseball throughout the summers, but he was also motivated by Pee-wee wrestling. I mean, all through from the time he was 3 all the way through college, he was really motivated by sports. His isolation really came from being teased by other kids, that kind of thing. So that was always, it was really difficult and frustrating. Krista, next slide. He did wear an auditory trainer in school, and I have to tell you that a story when he was in 3rd grade. His teachers, the teacher had gone to the bathroom, and she came back out, and she forgot to turn the auditory trainer off. Anyway, she was walking around the classroom, and he told her, he said, I can hear you walking. And she was really confused by that comment. She's told me that she reminds me of this every time I see her. And she couldn't really understand. She said, and Zach told her, no, you don't understand. She said, and you know, in those days there was polyester pants. And anyway, she said, I can hear your legs rubbing together. And she said, Zach told me I was fat without telling me that I was I was fat. Anyway, she reminds me of that story like at least once a year. Like I said, Zach became very super vigilant in his interest in sports all through grade school and high school. I think in some respects there was low expectations by some of the IEP team. They didn't think he would do well in a 4-year school as he got through high school, which I think it only increased his tenacity. But I mean, truth be told, if he had not had the support staff that he had at the school, with the special ed unit, with the audiologists, with everybody all the way up, Zach would not be where he was or is now. So he then graduated, and he attended Valley State University and the University of Mary for behavioral counseling, which always blew my mind because that takes a lot of listening to be a behavioral health counselor. And his hearing, I just didn't think was at that level that he would be able to do it, but he sure did prove me wrong. Next slide, Krista. So we did receive some assistance from Voc Rehab, and for those of you that are providers, I also want to make sure to note with you all that every state's Voc Rehab is very different. He moved to Minnesota from after he had received his master's degree in counseling. And once he moved there, there was no services for him in Minnesota. The wait list was extremely long. So he never did get any services when he moved there. He needed some new hearing aids, and we weren't quite sure how we were gonna finance this because it's not like they're cheap, you know, they're very expensive. And especially because his hearing aids were I'm thinking that his hearing aids were like 10,000 up or more for the set. He did while he was in Minnesota, I'm so grateful to them, found a service provider that put him on a he was part of a pilot project because they hadn't found anybody with his level of hearing that was still wearing hearing aids. So he did get a quite a nice set of hearing aids that were there were programmable ones that that really when and the day that he got them, I was coming home from a conference in the northern part of the state, and I had to pull off the road because it was the first time he heard a bird. So excuse me, they followed him for quite a while he was in Minnesota. And Dr. Martin, you probably know which company I'm talking about, but I don't want to say that because anyway. Next slide. I had to pull off the road and when he was describing to me because it was, you know, I couldn't believe it. So from Minnesota, he fell in love and he moved to Washington State. He now is the clinical director for the behavioral health clinics at the 12 bands that compose the Confederated Tribes of the Colville Reservation. He was there 18 months before he got promoted to clinical director. And, you know, it's hard not to be so stinking proud of him because you know what kind of obstacles that he went through to get to that point. Next slide, Krista. And I just wanted to say, so I'm part of the Family Voices Network, and we do a lot of educational trainings and things like that, leadership institutes. And at one of the leadership institutes, a couple parents that helped start Family or Hands and Voices in North Dakota, that was their goal when they left. The Leadership Institute was to get Hands and Voices started, and they accomplished that goal. So it's not like we don't have a Hands and Voices in North Dakota because we do, and they're also a great organization as well. But I've left you some contact information there. I've been an advocate for newborn screens ever since the EHDI project came out, had been part of the advisory for EHDI, and I can't say enough about the importance of getting those little screened early and regularly and and to keep on going. So I'm hoping that if you learned anything today, it was what not to do and also how to embrace the families that you're serving. So thank you very much.
Thank you so much, Janine. That was a wonderful, wonderful story. And we have a handful of comments that say you should be so stinking proud.
I am.
And lots of thank yous coming through. Any specific questions for Janine? Thank you all who provided some resources. I I appreciated you talking about, how he was teased a little bit in school. That hits home for me as well. So I just asked the group for some resources on how to help kids that are dealing with bullying. So thank you, everybody. And thank you, Dr. Martin. We'll go ahead and put the evaluation for today's session in the chat. Christine is going to do that right now. So please take a moment to fill that out. And we appreciate everybody for joining us today. Yes, please join us next week. Our speaker will be Amy Gaviglio. She's a genetic counselor, and she's going to talk about compassionate care strategies and having difficult conversations, especially when giving some of that diagnosis news. So yeah. Thank you so much, everybody.